How can the anesthesiologist impact oculocardiac reflex during strabismus surgery?
We want to make an opening all the way down to sclera. Then we're going to pick the big Jansen. And we're doing the first oculocardiac reflex on the left inferior rectus. What do you have for a heart rate?
Got 125.
Okay.
Starting at 78. This can influence safety as an anesthesiologist deals with routine strabismus surgery. The Alaska Oculocardiac Reflex study has been continuous monitoring of strabismus cases from 1992 through the year 2020, separating cases with Anticholinergic and cases that are reoperations. What about the influence of the surgeon in an oculocardiac reflex? We know that the vertical recti have greater bradycardia and the lateral rectus least. More tension on the muscle produces more oculocardiac reflex, and retrobulbar block can eliminate the oculocardiac reflex. What about the patient? We know that younger patients have greater percent oculocardiac reflex. White race seems to be more bradycardia. And there's some evidence that some patients with reoperation are prone to oculocardiac reflex, but this is not dramatic. But in this, we look at the influence for the anesthesiologist. The sample size of studies is very important. If we use a uniform stimulus for oculocardiac reflex and show in this frequency distribution the cases of bradycardia, we notice that there is a wide standard deviation. As a result of this, in different types of oculocardiac reflex studies, if you want to know a 15% difference, it takes about 33 patients. If you want to know a 5% difference, it takes almost 300 patients. And to tell a 3% difference takes over 800 cases. The Alaska OCR study has enrolled almost 2,700 patients with about 170 eliminated with anticholinergics and 446 reoperations. That leaves almost 2,500 original cases without anticholinergic. What about the impacts that the anesthesiologist plays in oculocardiac reflex? Well, IV atropine has a dramatic reducing effect on the bradycardia. What about opioids? Opioids increase bradycardia during oculocardiac reflex, measured by percent change. Of these, hydromorphone, fentanyl, and remifentanil had a great augmenting effect on bradycardia. As far as muscle relaxants, there's a little bit of an increase in bradycardia due to rocuronium. Precedex does cause an increase in the percent bradycardia. And we also found that dexamethasone IV also did. As far as inhalational agents, not too much difference. With CO2, having the patient well ventilated reduces bradycardia. And deeper concentrations of inhalational anesthetic also protects against bradycardia. Propofol use did not seem to change oculocardiac reflex, and nitrous oxide percent also minimally affected. So the anesthetic effects from this large study show that you can inhibit oculocardiac reflex with sufficient doses of anticholinergics, deeper anesthetic, and well-ventilated patients. You can augment the bradycardia in oculocardiac reflex with fast-acting opioids, dexmedetomidine, and perhaps dexamethasone. This allows you, the anesthesiologist, to have a very protective effect on oculocardiac reflex during strabismus surgery, be careful that the patient is well oxygen saturated and has good normal blood pressure before attention is applied to the extraocular muscle. Thank you very much.